So very good evening to you, Dr. Chapman. It's great to see you tonight. Of course, for you, is it 2 o'clock in the afternoon?
Well, good evening to you, Dr. Wilson, and it is afternoon for me. But I'm thrilled to be chatting with you about an issue we're both extremely passionate to increase awareness and really a call to action to all of your colleagues to help us change the current paradigm of care.
That's right. What we're going to be talking about tonight is really very important. We're going to be talking about the recruitment of appropriate numbers of women into clinical trials and research. Isn't that right?
Yes.
So I'm going to do a brief introduction of myself for people who may not know me. I'm Dr. Nina Wilson, and I set up a clinic focused on women's health in England, and we really focus on the gaps in women's health, the things that haven't traditionally been recognised or treated very well for women. And I'm also a clinical advisor at the ABHI, which is the medical device industry trade body in the UK. And that brings me into contact with all elements of the healthcare ecosystem, from research to healthcare delivery and innovation. And I'm speaking with Dr. Chapman this evening specifically about that issue of recruiting appropriate numbers of women into research. Dr. Chapman, perhaps tell us a bit about yourself to begin with.
I will. It's a privilege to be here with you, Dr. Wilson, and I am a heart failure cardiologist by clinical training and practice, and became passionate about this issue right as I completed my cardiovascular training. My mom, who had lived with me during my training to help take care of my two young sons, was diagnosed with heart failure just as I finished my fellowship. And I was incredibly humbled because I never saw her at risk. She had had an evaluation by my cardiologist when I was a medical student due to a left bundle branch block and an abnormal stress test. She underwent a heart cath, and I was told by my professors that she'll never get heart disease. She didn't have any traditional risk factors. And at that time, of course, she didn't have epicardial disease, but we didn't truly recognize the importance of the microcirculation. So fast forward at the completion of my training, nearly 10 years later, she's now diagnosed with heart failure, an ejection fraction of 30%, and living in my own house, and I never saw her at risk. So I began to comb through the literature, the clinical trials, and realized that women were not represented in our current clinical trials, and hence why my professors never educated us during training that women were at risk, despite epidemiologic data at that time that showed it was the greatest risk factor for women, and the number of women who had cardiovascular disease exceeded men.
Right.
So I became acutely aware when it impacted the most important woman in my life, my own mother, and I began to look at patients who were referred to me for advanced heart failure and consideration of cardiac transplantation, and saw many of them were missed in the early stages of their disease, when there was perhaps a greater opportunity to slow the progression or even reverse their disease. So I recall in the early 2000s giving grand rounds at Texas Heart Institute, Baylor College of Medicine, saying, do we have clinical evidence to treat women? And the answer was no, we don't.
I mean, I'm just going to pause there for us just to reflect on, and me particularly, just to reflect on what that means, everything that you've just said. So she was getting the best care by the sound of things. She was getting very thorough care from people who were very highly trained in our the knowledge that we have, and she was having tests that, according to the thresholds of those tests, were showing that her heart was entirely healthy. Is that right?
That's correct. Interesting. I was at the University of Virginia during my training, and during my tenure there, my chief of cardiology, Dr. George Beller, was president of the American College of Cardiology. So she was getting excellent care by some of the best cardiologists in the world.
But just the knowledge and the tools that we have don't fit for the women that we see.
Absolutely. And it really drew attention to me with the lack of evidence that drove our guideline recommendations, as well as the awareness by physicians in practice and in training of the risk that women have of developing cardiovascular disease.
So that's an important point as well. Can I just ask you, how old was she when she was going through all these tests?
My mom had my twin brother and I when she thought she was going through menopause. So she was in her early 70s at that time, but had been, extremely fit, no traditional risk factors. And interesting, in looking back, her hypertension had been diagnosed as white coat hypertension. When in fact, by the time she was diagnosed, she had marked left ventricular hypertrophy and had had undiagnosed, untreated hypertension for years.
So she did have what we would consider one of the traditional risk factors. She had high blood pressure, and perhaps due to some of the way we think about who gets these kinds of conditions, in her, it was put down to this is something that has just happened sporadically due to the stress of being in a doctor's surgery, and the rest of the time when you're going about your normal life, it's absolutely fine. So they said, oh, it's just white coat hypertension, and missed the opportunity to treat that. And then it caused the thickening of the heart wall, which ultimately was part of the process that led to her heart failure. I think that's what you're saying.
That's correct. And interesting enough, at the time she was diagnosed, I sent her back to my mentor who directed the cardiac transplant program there and asked the question, shouldn't we repeat her heart cath? It's been 10 years since we looked at her coronary arteries. And his response to me was, no, she's not having chest pain. She doesn't need a heart catheterization. So she was started on traditional guideline-directed medical therapy for heart failure with reduced ejection fraction. And 2 years later, developed classic angina, which prompted admission to the hospital, transferred back to the University of Virginia, where she underwent another coronary angiogram, showing at this time 3-vessel coronary artery disease with a calcified aorta, and her right coronary looked like a string of pearls. Her left anterior descending artery had a 99% proximal lesion with a post-stenotic dilatation that appeared to be a Barry aneurysm coming off of her LAD. So at the time, she was considered high risk for cardiac surgery due to her calcified aorta, and high risk for interventions due to that post-stenotic dilatation, and was turned down for any opportunity to have revascularization.
Okay, so a couple of years before, you'd asked for that to be looked at, and they'd said the vessels are absolutely fine because, excuse me, she's not having chest pain. But 2 years later, she's being turned down for those same treatments because it's too late, effectively. And I just picked up on, you said 99% stenotic. So one of these vessels, one of the main vessels to the heart, was 99% closed, blocked. Is that what?
Yes.
That's what they found?
Yes.
Okay, and this is the vessel that gets, in England, I don't know if it's the same in the US, we get taught in medical school, it's called the widowmaker.
That is correct.
So it has this sort of sex-based name that is about men dying, not about how this can happen in women.
But interesting enough, Nina, it's called the widow maker, not the widower maker.
Exactly.
Because it's referred to men as having that disease.
It's the vessel that traditionally gets blocked and causes men to suddenly die. But of course, it's happening for women as well, but we haven't really recognized that. And I think you said that earlier, that the awareness of how much women could have been at risk of cardiovascular disease was very low among very highly trained professionals.
Yes.
So that, I mean, that's a big story. That's a lot to go through. I picked up that there was a lot of clinical detail in that story about the different elements that were present in your mum, the vessel disease, the lack of awareness around at an earlier stage about microvascular disease, so problems affecting the smaller vessels, and the high blood pressure and so on. And really, if you put that all together, it sounds like there were many, many opportunities that could have flagged concern, but didn't.
Yes. And as I reflect on those individual physicians, they're good people. And they didn't intentionally want to miss this in my mom or any of their other female patients, but it was a lack of education, awareness, and really clinical evidence that gets back to recruitment of women into clinical trials. As I reviewed clinical trials for heart failure, some of the very early, even medical therapy trials enrolled no women. And certainly in the device space, we see women are still very underrepresented in
Mhm.
all of our cardiovascular medical device clinical trials. We've had some improvement in some of the current cardiovascular medical trials, but they're still underrepresented. And there's still an unconscious bias that often, especially younger women or women who appear fit, are not at risk of cardiovascular disease.
So we're missing the data in terms of research around health and disease. We're missing the data in terms of studies on what to do to intervene and how effective that is, and how effective, whether it's a device or a medicine or some kind of treatment. If we haven't got enough women, we can't determine how effective that is in women. And so, I mean, my perception is that what we've been doing is these studying these things in men and just assuming that it will apply to women, but then finding now that that's not the case. Is that right?
That is absolutely correct. And when you look at women who present even with a heart attack, most of them do not have classic chest pain. Up to 10% of the time, their only symptom might be jaw pain. They may have fatigue or shortness of breath, or more non-specific symptoms that often leads them to be undiagnosed. And in fact, studies have shown that more women are discharged from an emergency department with a diagnosis of panic attack than men when they're actually having a heart attack, which would
Mm.
make anyone anxious and appear panicked.
Yes,
Uh,
yeah.
so we do have a lot of work to do, and that was part of my decision to move from clinical practice, which I loved taking care of patients, to assuming an industry role and a role as a clinical trial sponsor to really focus on the recruitment of women so that we have better evidence to both diagnose and treat women and ensure that our therapies are both safe and effective for women.
Hmm. Well, it's very important, and you've been doing this for several years now, haven't you?
I transitioned in 2020, so I just celebrated my 5 years in an industry role and have been bullish within ABHI, now part of Johnson & Johnson, about breaking down barriers to recruit more women into clinical trials. And if you think about why women don't participate in clinical trials, is we're often as the head of the household, caring for everyone else in our families, whether it's a spouse, young children, aging parents. And if we're juggling a job outside the home, as well as those responsibilities within your own family, oftentimes adding another responsibility of additional clinical follow-up visits to participate in a trial is burdensome for women. And as you can imagine, especially women who may have younger children and incur additional cost for those additional follow-up visits of childcare, transportation, that can be a significant barrier to their participation in clinical trials. So first, overcoming any legal and regulatory issues, we now have recommendations from our regulatory body, the FDA, that it is acceptable to compensate women for those additional costs. And then getting through legal approvals within industry sponsors has been another big challenge, that you're balancing enticing patients to be part of clinical trials versus alleviating barriers to allow them to participate has advanced in the last few years to help us at least reduce those barriers to encourage more women to participate. The other additional strategy is trying to decentralize clinical trial follow-up visits as much as possible and offer the opportunity to have a virtual follow-up visit or a remote visit in their local community that could be combined with any imaging or laboratory tests that are required, reduces that transportation barrier for women, and will help encourage more women to be involved in clinical trials.
Okay, so we're getting into some of the ways that you have found are some of the barriers and how to overcome those barriers, because I think in the discussions that I've been party to recently, there's a lot of recognition of needing to recruit more women into clinical trials, but we need to take that to the next steps, which is, well, what do we actually need to do to make that happen, so that we can actually get this appropriate research. And this is where you have a march on everybody. You have the experience, because this is what you've been doing very passionately for the last nearly 6 years, I guess. And you've mentioned a couple of those things already. So one of the key barriers is the time and cost taken or required to travel to a unit and take part in a trial. And so if that can be removed or mitigated, that helps women participate in trials. What other things have you found to be barriers that you've found clever ways to overcome?
Well, certainly it's important that women trust the clinical trial process. And often that begins with the clinical trial leadership, even at the national principal investigator level, as well as at their individual site, and who is approaching women to participate in a clinical trial. So another issue has been, historically, most of these clinical trials have been led by men, including the national principal investigators, as well as the steering committee and the site investigators. So we have been very intentional, and I'm proud to say have had now three women who have been named national PIs since I joined ABHI Med, now Johnson & Johnson, at the highest leadership level in the clinical trial, to have a woman incorporated in developing the protocol and the clinical trial execution. We've also had a deliberate attempt to include women as part of our steering committee, as well as reaching out to women who are site principal investigators. One challenge, however, with medical devices is you need to have women who have a skill set to implant a device, for any implantable device. And we still have a paucity of women who are cardiac surgeons, as well as women who are interventional cardiologists. And even as a trial sponsor, to support programs to encourage more women to pursue those fields is critically important, as well as to provide them opportunities for career advancement and obtaining clinical trial skills so that they can then become clinical trial leaders as part of their career and lead these initiatives to ensure that women are represented in all of our clinical trials.
So it's across the board, as you say. It helps. You started by saying it really helps participants trust the whole process, but also that you see it as part of your role to support clinicians who are coming through to develop the skills and to be in a position to take on those roles. And again, traditionally, the pool has not been very large from which to choose from in order to put women in those roles in research. Is that right?
That is absolutely correct. And there, are two skill sets. Number one, a skill set to implant a device when you're having a medical device in a clinical trial. And those can be busy clinicians, but there's also a secondary skill set about the clinical trial process. And that's for implanting and non-implanting physicians to obtain those skills about clinical trial development, as well as, even serving on a data safety and monitoring board or a clinical events committee to adjudicate events. Those are not traditional skills that are taught in clinical training, and working with national societies to support programs that will offer training for interested physicians to obtain those skills. We work with a small think tank called the Heart Failure Collaboratory and support their efforts to train interested physicians who are early in their career to be able to sit on data safety and monitoring boards so they can again develop the skill set and the track record to become future clinical trial leaders.
Okay, so that's interesting and that's important because I can relate to that from my own experiences. You train in medicine, you train in the sort of clinical world, but what you're talking about is trials. That's slightly separate from medical school and medical training and a medical career. It's something slightly separate that some people do pursue, but it's about opening that door to make it easier to get those additional skills. And I've seen that a lot in my career with digital skills and regulatory skills, and I've worked in various different fields that actually a lot of doctors don't get to work in because it's not the traditional route. So
Absolutely.
yeah.
And as a trial sponsor, it's a huge risk when you bring together external experts to serve on a steering committee to help with a protocol design, a regulatory submission, execution of a clinical trial. You want to recruit physicians who have that skill set. It's very risky to put together a leadership group who haven't had that clinical trial experience. So you have to step back and say, historically, it's all been men who have sat in those leadership positions, who've acquired those clinical trial skills. And you have to be very intentional to encourage women who are young in their career to pursue those additional skills, and align them with mentors who can be men or women to help mentor them through that clinical trial process so that they will then become steering committee members and ultimately principal investigators to lead, national or multinational clinical trials.
And how are you going about that in your role?
So we now have, I'm happy to say, our most recent steering committee is one of the most diverse, with sex, age, race, and ethnicity, as well as really where they practice, whether it's in a community or in an urban academic setting. And we now actually have a female patient who has become one of our steering committee members to provide a patient's voice throughout the entire clinical trial process, from protocol development to site selection to execution. So it starts with really having that as an intention and ensuring that the people you want to include have the skill set And if there are not enough candidates with that skill set, to try to open up opportunities for interested women to obtain those skills. And so we work with both the Heart Failure Collaboratory to obtain skills for serving on a data safety monitoring board. And we work with the ACC, who has a year-long process to train young physicians on the clinical trial process and the skill set necessary to pursue clinical trials as part of their academic or non-academic career.
And if I just come back to the trust element that has been reported, do you think it's just the presence of women in those roles, so their visibility that helps with the trust, or is there more to it?
And of course, this is my own opinion. I think it's more to it. I think that certainly women, by and large, tend to be more servant leaders, and their egos are not as big as many of the men that we work with. So they tend to think more during the trial process about the population we're serving, and how is this clinical trial going to answer a clinical question, and are we able to recruit the patients who actually have the disease that this therapy will ultimately serve. So I think that they serve a purpose in those team dynamics with steering committee discussions and bringing that unique perspective. And I think women trust other women. As you know, a female cardiologist, when I was at the Texas Heart Institute, all of my colleagues were men. When I would approach a woman to enroll in a clinical trial, I would sit down and look at them face to face, give them ample opportunity to ask questions, talk with extended family members. And most of the trials didn't have to have, a decision within 5 minutes like an acute heart attack trial might. So there was plenty of time for that dialogue back and forth and this has been studied and shown in studies, men tend to stand up and push patients to make a decision within a few minutes, and not give them the opportunity to have those discussions with their support group, whether it's a spouse or extended family members or friends. And that does influence a person's decision whether to participate in a clinical trial or not. And we found, especially with women who by and large can be more risk averse, they benefit from having that additional time to ask questions, to better understand the potential benefits or risk of being involved in a clinical trial, and to pull in their extended support group to help make that decision.
Okay, so the decision-making process is maybe slightly different, and women like to perhaps take a bit more time to reflect and think about it and use others as a sounding board. So if you can create that space for them, they're perhaps more likely to ultimately come and say yes.
Yes.
Okay.
And we found that women investigators tend to offer that more so than men. And it's not that men can't be taught, but those are the soft skills that it's important to recognize do influence a patient's decision whether to participate in a clinical trial or not.
Mm-hmm. So any other things that you found on the softer side, perhaps the more subtle things, maybe things you didn't expect?
And certainly I would say things that were part of my unconscious bias and I wasn't as aware of are really all of your patient-facing materials. For example, we had a clinical trial where the logo for the trial was the silhouette of a person, and it was the silhouette of a man with our device inside the silhouette. And the image was created by one of my colleagues who is a woman. And I didn't even recognize that that is a subliminal message to women who are being approached for that trial when they see that logo, that it's the logo of a man that's not inclusive of them. And it was really when we contracted with DCRI, which is Duke Clinical Research Institute, to bring together a patient advisory group, which is made up of physicians, research coordinators, patients, and caregivers, that they recognized that our logo was excluding women.
Mhm.
And once they brought that to our attention, we're like, oh, I can't believe I didn't even recognize that. And we went back and changed our logo to be a heart that doesn't have a sex or gender related to it. And that's much more uniform in all the patients that we approach. So we also started looking at all of our patient-facing material, including brochures that tell patients about the clinical trial. And many of those brochures had all men, both as the patient and the provider.
Mhm.
And so we've gone back and intentionally changed all of our patient-facing materials so that they're much more representative of men and women, different races and ethnicities, both as physician and providers as well as patients, to be much more inclusive. So as a patient looks through that brochure, they can see themselves participating in the clinical trial, and they're not looking at a brochure that's all white men.
Mm. So that's interesting, and it does make sense that if you're going to enter into a world or do something that you might not have done before, that it might be the unknown. There may be slightly scarier elements to it. Medical things often create a degree of stress for people. Um, if you're looking for cues as to what this might be like, then you're looking to see if are you going to be comfortable? Are you going to fit? Can you see yourself as you describe in that trial? And if you reflect that in your materials, if patients and participants can see that, then there's an unconscious element that reduces that distance that they have to cross in order to participate.
Absolutely. And it's all about helping patients feel comfortable and trust the trial process. And when they
Mhm.
see women who reflect themselves, they're much more likely to want to participate and be part of the process. Now, we recently had an internal summit that brought together all of our clinical trial operation teams, and we challenged them with a Shark Tank competition to create an initiative that would help us break down barriers and be able to enroll underrepresented groups in clinical trials. And several of the recommendations were phenomenal. The winner was one called the Minus 100 Day Initiative, which is where when you start to look at a site to participate in a clinical trial and initially you start with a questionnaire, we call a site feasibility questionnaire, about whether that site has the infrastructure in place, the patient population we're looking to study, to see if it's a good fit for the clinical trial. Well, in that site feasibility questionnaire, which is usually 100 days before you activate the site, we start to ask that site, what do you see as barriers at your site to prevent enrollment of these underrepresented groups? And that gives us an opportunity to personalize and tailor our approach to each individual site, where some hospital systems might have a transportation in place that would help patients be able to provide transportation within a certain range to the clinical trial site. So that may not be a big barrier for them, but they may foresee, the lack of caregiver support as a barrier, where another site might treat a large population of patients who have to drive quite a distance to their site, and that the transportation cost is a major barrier. So it allows us to partner with individual sites and tailor and personalize our approach and support at those sites to ensure that they can enroll underrepresented groups. What we found initially when we would go into sites, say, for example, our highest enrolling site in one of our clinical trials, I remember, had 95% men. And I went to visit the site, and the lead research coordinator is a Black woman. And when I talked to her about the underrepresentation of women, she became very defensive
Mhm.
and didn't want to partner with us to look at how can we recruit more women at their site, but felt very offended and just kept coming back, but we're the largest enrolling site in your clinical trial. And so that's why we found starting with that site feasibility questionnaire and developing a partnership where together we identify potential barriers before enrollment even commences, that we can put additional support in place, was much more effective than after the fact saying, why have you enrolled 95% men and no women? We also took it one step further to, as we look at publications for our larger clinical trials, often the first author is the highest enrolling site, but we also elevate sites that enroll a diverse patient population so that that gives them a higher priority level on authorship. So again, they may not have enrolled the highest number of patients, but they enrolled patients that really represented those from underrepresented groups, that we do give an academic sort of appreciation for the amount of time it takes to often enroll underrepresented groups that may have more distrust and need more time to explain the clinical trial process.
Interesting. So, a couple of really great points there. Starting early and having normalizing that conversation about planning how to get appropriate numbers of underrepresented groups in. And did you say you actually have a checklist for that? Is there a paper document?
We do. It's part of our standard questionnaires that we ask all sites at the site feasibility questionnaire. And then as we move along the site selection process, we do start to put support in place to tailor for that individual site based on where they perceive the largest barriers are. And the last aspect of what we have created, which believe it or not has been relatively new, is demographic dashboards for all clinical trials that are shown at all research coordinator meetings and all PI meetings. So everyone is aware of how many men, how many women, how many patients from each racial and ethnic group have been enrolled in the clinical trial, to increase awareness to the entire trial community for that specific clinical trial about where the gaps may be. Recently we had a surgical trial that one aspect of the trial was being conducted in Europe, predominantly in Germany, and we only had 4% women. And I said to my German colleagues, the surgeons who were enrolling in the trial, that it's really important to look for women and other underrepresented groups so that we will be left with data that is generalizable to the patients who have this disease. And he said to me, well, we don't have them in Germany. And I just laughed. I said, I'm pretty confident you have women in Germany, and you only have 4% women enrolled in the trial, and that doesn't really reflect the number of women in Germany with coronary artery disease. But he had never thought about it, and had never thought. He goes, well, we just enroll anyone who comes to us. And I said, well, we might need to back up and start with your referring physicians to educate them about the importance of looking for this disease and their women so that they can refer more women to you to be considered for clinical trial participation. So many times you have to take a step back and see, does the education need to go beyond that trial site to their referring communities to educate them about the importance of enrolling underrepresented groups, especially women, in clinical trials.
Wow. So, I mean, it does get bigger and bigger and bigger in a way, because, as you say, it's part of it's about that awareness, and previously people who were just enrolling in the trial, that's what was taken, but you've described that you need to be a little bit more intentional about that. But they're relying on the referrals that are coming through, that are being made by people who haven't had this awareness in their training, and therefore aren't spotting it in women, and therefore can't refer them on. So, I mean, there really is a job for us in medical schools and medical training, don't you think?
And in the US, there's been a lot of discussion about increasing awareness about participating in clinical trials and why that is so important.
Mhm.
And there's still, in the US particularly, there's a lot of distrust about the clinical trial process, really based on Tuskegee, and with good reason. So it's important to build that trust in communities and build that trust by partnering with community leaders and increasing transparency about the clinical trial process, following up with clinical trial participants about the outcomes of the clinical trial and why their participation has been so important to create evidence to help us better treat people who look like them.
Mm. So can you give us an idea of the impact that this might have had in the time that you've been in post?
So I will say it's still disappointing in our surgical trials, where again, we have very, very few cardiac surgeons who are women. And I think a lot of that is part of our clinical trial leadership. So we're investing and helping to encourage more women to pursue cardiac surgery and then to acquire those clinical trial skills. So I will say we've made a little bit of movement, but it's not anywhere where any of us hope it will ultimately be. Um, and it's been better in our interventional cardiology trials where we're seeing more women. Again, we're supporting women to pursue interventional cardiology as a career, supporting women who are early career in interventional cardiology to help with their research careers as well as their clinical trial skill sets. But we have seen, early on, even, a 2 to 5% improvement in clinical trial enrollment, which again, it's moving in the right direction. But our most recent trials that now have, from the leadership, equal representation of women at the NPI level and at the steering committee, we're just going to start enrolling this year. So we've also just implemented our negative 100-day initiative. We did it after our previous trials had already commenced, so it was on the back end of those trials. But all of these initiatives will be at the front end of our upcoming trials. So we're quite excited to see what sort of impact that will have. And importantly, we're keeping a dashboard to educate everyone involved in clinical trials within each trial, as well as an overall dashboard for our entire company, how we're doing as a company to enroll more women and more underrepresented groups across our clinical trials.
It's surprisingly powerful what happens just when you start to expose the numbers, isn't it?
Yes, and I will say, in tandem with this, we've also revamped our educational process where we support a lot of educational events. Historically, we've had a lot of mantles where they're just all men on the panel.
Mhm.
And even my male colleagues within the company are very strategic when we choose faculty for varying events, that we have representation of women as at least one or more of the faculty members. And we have a saying, no more mantles. We will not have any more educational events where there are only men presenting.
Mhm. Because it's for everybody. It's about being able to see yourself and see men and women contributing to this.
Yes.
So I mean, you've done a phenomenal amount. What do you see for the next 10 years? Where would you like this to go?
I think if we, historically, especially in the medical device space and cardiovascular trials, women have been under 20%, where in fact, their prevalence of the disease is closer to 50%.
Mhm.
And ultimately, I would love to see the prevalence to participation ratio be equivalent for men and women. But certainly, as we can move closer to 50%, I would be very happy to see numbers north of 40% for women included in our clinical trials. And that would be more than double to what I've seen in clinical trials. And I will say 25 years ago, many trials had 0 women. But we've sort of plateaued at about 20%, and it hasn't moved beyond 20% in the last 15 years. So I think to start to see that move and really educate women why it's so vital for them to participate, not only for themselves and often women as caretakers for their family members, how it could benefit even their own families to create clinical evidence that would improve our ability to treat the women in their family.
And I think that's what it comes back to, doesn't it? Because as you're talking, I'm thinking back to where we began with the story of what happened to your mum, and just how at each step things were missed. It wasn't recognized. And that's with that participation, with that sort of 50% representation, we can start to unravel what is going on for female heart disease, know how to detect it, know how to treat it properly.
And the American Heart Association launched a campaign, Go Red for Women, gosh, about 20 years ago now. And even with Go Red for Women, we've improved the awareness. But if you survey women in the US, most women still perceive breast cancer as their greatest risk.
Right,
When
we have the
cardiovascular
same.
disease remains the #1 killer of women worldwide.
So still women themselves don't recognize just what a risk it is to them. I think we're in a similar position in the UK too. And it's been absolutely fantastic to talk to you this evening about all that you've achieved, because, as you know, later this month, we have the ABHI Global Women's Health Summit, with one of our key themes being focused around research. And we'll have research leaders from the UK and globally as well, talking about how to tackle this issue, how to recruit more women into trials and into research. And I think what you've just described this evening are some really practical ways of making this happen. And it's really interesting to note that, yes, there are some clear practical technical issues, but actually the soft skills are quite a strong part of it as well. You know, that really makes a lot of sense to me in my work as a general practitioner. A lot of it's about the communication, the relationships with people, the trust that you build, and the understanding that means that people can collaborate successfully.
Absolutely. And I will say, even in talking with my male colleagues, many of them are quite defensive when you start talking about this issue. And I have found sharing stories help with that emotional connection to why this is important.
Mhm.
And certainly, I'm not judgmental. I missed heart disease in my own mother and never saw her at risk. But in telling, whether it's her story or one of my patients' stories, um, it's important to use those patient stories, because that's often what sticks, even with their own colleagues,
Mhm.
to help them change their behavior, to remove those unconscious blinders so that they can see the risk of the patients in front of them and take the additional time that's needed to help recruit women into clinical trials so that we have the evidence that's going to help treat even our own family members. So I want to thank you for your passion and your investment in improving recruitment of women, and all those attending your conference. I wish I could be there with you, but I applaud you, and I would say stay in the fight, because it may be your own life that you're saving.
Incredible. Yeah, thank you. And we really miss that you can't come to the conference, but thank you so much for this and for your support.